Well, why don't we get started? It's 4 to 5. I want to welcome everybody to another nice presentation today with the Transplant Institute lecture series. I just want to remind everybody to put your pager or cell phone on vibrate or silent since we're recording this session. Today we're very lucky to have Dr. Humar coming to visit with us from the University of Pittsburgh. Dr. Humar is the clinical director of the Thomas Starzl Transplant Institute, and many of you may be familiar. Many of us trained either through Pittsburgh or through a pedigree from Pittsburgh in liver transplantation. Dr. Humar he's a native of India, and he did his education at the University of Ontario, where he also did his surgical residency, and then went to the University of Minnesota and added quite a bit of training there and stayed on staff and was the chief of the liver transplant program there. Made a lot of contributions, grew the living donor program, and is a prolific writer, wrote on many subjects and any subject you want, whether it's kidney, pancreas, or liver transplantation. He's a member of many societies. He's also on the Council of the American Society of Transplant Surgeons. We work together there, and he is also on many editorial boards, and he's currently an associate editor for clinical transplantation, right? And the one thing that Dr. Humar brings that is very unique, is besides being a prolific writer, is that although he's got a quiet demeanor, he is a master surgeon, and that can be bad and good depending how you look at that in the operating room. But he also is a very good thinker. And when he went to University of Pittsburgh, he landed on a program that had a lot of issues going on, and not the least of which is leadership challenges and operational challenges. So he landed in a setting where there were process issues and concerns that resulted in adverse outcomes. And so there was a significant experience that he had to deal with, build new teams, deal with adverse events, especially in the current regulatory environment. And him being the person that he is, shares his knowledge, and is a good thinker and process-oriented, he is willing to share with a great degree of transparency what you go through as a program when these kind of situations happen, and how that affects your program, your staff, your people, and how do you preempt it, and how do you deal with it in the public eye as well, and your leadership. So thank you, Dr. Humar, and please join us.
Thank you very much, Marwan, for that very kind introduction and for the invitation to come here and speak. It's been a terrific afternoon. So this is a little bit different from what I usually give talks on, and I have to admit, in all honesty, not what I'm most comfortable speaking about. I'd be a lot more comfortable coming in talking to you about how to split a liver or do something of that nature. But rather, I'm going to talk to you about how to deal with an error when it happens in your program, and how to manage the potential consequences and damage that can occur from it. None of this is anything that's been learned from a book or from classes. This is all from, as they say, the School of Hard Knocks that we learned as we underwent problems through our own experiences at our program, which I'll go through in a little bit of detail. So I have no financial relationships to disclose, and this talk is definitely not going to be about any immunosuppression drugs or any products. So I just want to go take you through the case that stirred this all up for us. This was started with a kidney donor. She's a 40-year-old healthy kidney donor, nurse by profession, who was donating to her husband of 18 years duration. During the kidney transplant evaluation, there was really nothing that put her in the high-risk category. So she was not a nurse by profession. She was a remote caretaker for an HCV-positive relative in the remote past. And really, other than that, there was really nothing else in her history. No use of IV drugs, no blood transfusions. She was in this very stable long-term relationship with her husband, as I said, of 18 years duration. Her exam was all unremarkable. Her evaluation showed an abnormal mammogram, and we had actually concentrated on that initially and put her through a number of other investigations, including a biopsy, all of which came back negative. this was one of her lab sheets, and at that time, this was about 3 years ago, we were still in using paper charts for everything, and this was part of her paper chart. And this was one sheet out of about 150, and these are her labs right here. And if you look through it, there's no question that she was hepatitis C positive. Okay, so there it is right there at the very bottom, right below the hepatitis B surface antigen, which was negative, hepatitis B surface antibody, which was 22.6. It doesn't say positive or negative, but that's definitely positive, as indicated by this little star that's right next to it, showing that it's an abnormal result. So there's no question that she was hepatitis C positive. That, unfortunately, was not picked up. So our process at that time was that the patient would come in for their evaluation. It was done at one time. They would see the surgeon, the medical doctor, and they would be sent for all of their labs. The labs would come back, would be initially reviewed by the donor coordinator, and then subsequently by the donor surgeon who had seen her at the time of the evaluation. And so we did that. The case was reviewed by the donor coordinator, who unfortunately missed that test. She handed the chart to the donor surgeon, saying that it was all fine. He reviewed it and also unfortunately missed that positive hepatitis C test. And therefore, she was approved by the coordinator and the surgeon to be a donor. The case was presented before our multidisciplinary team by the donor surgeon, so was presented the same way that I'm presenting to you, essentially, with the specifics. And he, as I said, had unfortunately missed that she was hepatitis C positive, and that's the information that was transmitted to the selection committee, and therefore she was approved for donation. The case was scheduled, and unfortunately the transplant happened. This was before the days that we were actually doing NAT testing. This was actually just a couple of months before NAT testing was introduced as part of our routine. So this was discovered after the fact, as the coordinator was going through some charts and saw that. First thing we did was notify the donor and the recipient, called them both in and told them exactly what had happened. We notified UNOS immediately once we figured it out. They put our living donor transplant program on hold, all living donor transplants, liver, kidney, adult, pediatrics. Our pediatric hospital was actually a separate freestanding hospital, but nonetheless it's one program, and therefore UNOS put everything on hold. We did an internal root cause analysis of the mistake and designed a corrective action plan, which we then put into place to, now this is all the time while the program is on hold. We put it into place. UNOS then sent a peer review board, which essentially consisted of 4 people who came and conducted an on-site survey, looked at our root cause analysis, looked at the corrective action plan, and made the recommendation that we resume operations. And therefore, we restarted living donor transplants. That process took 3 months to do. So for a 3-month period of time, we did not do any live donor transplants. That recommendation was given to UNOS and the MPSC committee. The MPSC committee had agreed that the program would resume, but nonetheless placed the entire program, the entire transplant program, because you don't get one specific portion put. The entire transplant program was placed on probation, and that's where we stayed for a period of 1 year, which is what the probationary time period is. And if you're aware of what probation involves, I hope you're not, but if you are, it's fairly involved. You're still allowed to perform operations and conduct your business, but essentially you have to tell every one of your patients, every patient that's on your list, every patient that's undergoing evaluation, every patient that you've transplanted, that you are currently on probation. Okay, the reason why you're on probation, what your plan is, etc. So you can imagine the problem associated with that when you're seeing a patient for the first time in clinic, telling them that you want to do their transplant, and by the way, we're on probation. So nonetheless, it was a difficult time for a year, but we got through that, and we've been off probation now for over a year now almost, and getting back into the swing of things. So now, fortunately or unfortunately, we're not certainly the first example of a mistake happening, and we're not the first example of a mistake happening even in transplant. So let me just give you a couple of examples. This was a case in Taiwan, again, not too long ago. I think it was just about a year ago, where 5 patients received transplants from an HIV positive donor. And all 5, unfortunately, acquired HIV as a result of those transplants. And the problem here was that the lab tech who had performed the test by phone communicated to the donor coordinator that the HIV test is positive. And the coordinator heard the HIV positive test is negative. And that's what the coordinator recorded on the sheet, which then subsequently went out to all the programs, and therefore that's what all the programs had, that the HIV test was negative, when in fact it was positive. This doesn't just happen in the Far East or in places like remote places like Pittsburgh. This even happens in very elite programs and well-known programs. Duke Hospital is a very heavily publicized case in 2003. Actually, one of the first. I don't know if you saw the special that was done by CBS. It's called Anatomy of a Mistake. It's quite a compelling story. This was the story of Jessica, who's a young girl from Mexico who smuggled across the country, across the border illegally because of her medical problems and being unable to be treated there. Family had no money. The family took her in and did extensive fundraising and put her on the waiting list. She needed a heart and lung transplant. The chief of pediatric surgery got the call in the middle of the night, offering him heart and lung actually it was for someone else. He said, "This is not the right size for my patient, but could I have it for Jessica?" And they said, "We'll look into it." And about 12 hours later, they got back to him saying, "Okay, we've exhausted the list. You can have it for Jessica." And he just assumed that they were compatible blood types. Jessica was blood type O. The donor was blood type A. That information was told to him, apparently by the reports, maybe in the middle of the night. He doesn't recall. The donor surgeon is sent out. He doesn't know who the blood type of the patient, and because he's told several times that the donor is blood type A, he brings the organs back. They're transplanted. The patient comes off the pump, and they get a call from the lab that what's going on? This patient is blood type O. These organs are blood type A. And if you watch that, it's actually quite compelling. The surgeon describes his feeling. It's like an emptiness that filled inside of him. This feeling of helplessness, and it's really quite emotional. Jessica unfortunately developed severe rejection, as you would expect, multi-organ failure, and 2 weeks later was retransplanted actually with another heart and lungs, but unfortunately progressed on to multi-organ failure and died of multi-organ failure. This, if you, again, the paper's not far away from here, very recent, and so kidney is removed from a donor. This is a 6-antigen match donor, live donor, that the kidney and the transplant is being done sequentially. So the kidney comes out, is put in a container. The surgeon gets ready to start the recipient, and I think they actually started the recipient and go to look for the kidney, and they find that the kidney was discarded when they cleaned the donor room, and that could not be salvaged, and that kidney was lost. Fortunately, the patient subsequently went on to get another transplant several months later, but that case, as you can imagine, is now in litigation. So this is all just examples of medical errors, okay, where medical errors are not, unfortunately, are not uncommon. They're very common. What exactly is a medical error? It's, by definition, the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. So essentially, it's something going wrong, and it's not something going wrong like a complication, like a surgical complication where you might get a wound infection or a bile leak after a liver transplant. Those are potential things that can happen. These are actual errors, that you did something that you shouldn't have done, that's pretty clear that you gave the wrong medication, did the wrong, something of that order. Those are medical errors that I'm talking about. So this is, if you Google this, actually you can find out that medical errors are quite significant. So 180,000 people, according to some calculation, died in hospital every year as a result of medical errors that could have been prevented. Okay, 180,000. So preventable medical errors exceed deaths due to motor vehicle accidents, breast cancer, and AIDS. Medical errors, 5th leading cause of death in the United States in 2010. And 1 in every 25 hospitalized patients is injured because of a preventable medical error. All right? So this is not a small problem. This is a big problem. Compared to, some of the other things that we put a lot of attention into in trying to make error-free, for example, flying. So what's the risk per flight of dying in a commercial airline accident? 1 in 8 million. All right? So compare that to the risk per hospital admission of dying from a medical error, more than 1 in 1,000. Magnitudes difference. Okay, so obviously we have a long way to go. The airline industry has come a long way because the risk was 1 in 2 million back in 67 to 76. So you can see how it's decreased significantly since then. So medical errors have a number of components to it, but essentially I think when you look at all medical errors, there's the vast majority you can find that there's 2 components to them, okay? There's usually a human component to the error. There's some one particular person that makes a mistake, okay? And that's not, unfortunately we are human. We make mistakes, and you do anything often enough, you're going to make a mistake at some point. And so, that part is always going to be there. But often you'll find that there's a system failure in there also, that the human error occurred, yes, but then was allowed to propagate, or was allowed to be carried forth, or was allowed to have a consequence because there was a problem with the system, okay? And that's the place where we have probably the most scope in terms of making an intervention or trying to improve. So there are lots of different types of medical errors. Diagnostic errors, that's the radiologists know all this very well. They put up a chest x-ray and they say it's normal, and then there's obviously a little spot down in the corner that they just missed just because they rushed through it, or they just missed it because it was hard to see, or whatever. There's some descriptions of spots being, they thought it was dirt on there, and lots of different descriptions. Treatment errors, those are very, again, pretty self-explanatory. The wrong medication is given, the wrong dose is given. These are very common in a hospital setting. If you look at how many errors occur with heparin, for example, the wrong dose, 10 times the dose of heparin being given, it's staggering. You think that those could never happen, and yet they happen every day. Preventive errors. Now, this is something that I think we in transplant probably should be very aware of, because these are errors of where you miss out on doing things that you should have done that are preventive in nature. And a lot of what we do in transplant are geared towards that prophylaxis, getting labs to prevent something, checking CMV, this and that. And it's, if you're, let's say, for example, I'll give you an example, you're doing preemptive treatment for CMV. You're not using universal prophylaxis. So that depends on a system where someone checks that CMV on a regular basis and makes the point of it. Well, if that comes across the desk and, it slips and falls down and someone misses it, or it doesn't get faxed or gets faxed to the wrong number, those are all errors that can lead to a test being missed until the patient then shows up with florid CMV infection. Medical errors have a lot of consequences, and some of them are fairly obvious. Obviously, the physical problem to the patient. So if it results in death in the patient, that's obvious. That's what the consequence is. But many medical errors don't result in death of the patient. They result in some problem that can have a physical impact on the well-being of that patient, both for the short as well as sometimes the long term. Psychological problems to the patient because of prolonged course, prolonged recovery, prolonged repeated operations, etc. Leads to a loss of trust in the healthcare system, okay? Because here you are trying to build a rapport with the patient and you make a mistake, it's going to be very hard for you to build that rapport, build that trust again with that. Obviously, diminished satisfaction of patients and health professionals. If you've had a problem, you know, you're not going to be very satisfied with the care that you received. Loss of morale, increased frustration of health professionals, end of career. Okay, so that's potential consequence of a major medical error, and I'll talk about this a little bit more in detail. It's incredible the loss of morale and the impact that medical errors, depending on their severity, can have on the individual and on the team. Okay, and unless you are cognizant of that and specifically address those, that can sort of mingle and go on to end of career, and many different ways that it can end, and I'll show you a case where it ended very poorly. Society, every medical error has an impact on society, on the health of the patients, obviously, but on costs, and you'd be surprised at how much medical errors cost, or maybe wouldn't be, but nonetheless, adverse events, so that's just any side of any complication, but preventable adverse effects. So these are errors essentially. You know, roughly $17 to $29 billion cost to our healthcare system on a yearly basis. Okay, and that doesn't take into account lost income, lost household production, disability, etc. to the patient. That's just the healthcare costs in dealing with that error. Okay, let me just give you another case. So this was in Tuscany, Italy, February 2007. 3 patients received HIV-positive organs. So you can see this disease transmission. This is, you know, one of the reasons why UNOS and the CDC have gotten so involved in this, and why some of the processes, you think about what you do, they become so onerous and cumbersome, but it's because of cases like this and like ours that these processes have become so cumbersome in an attempt to try to prevent these. 3 patients received HIV-positive organs, and again, the error here was a documentation error. Error in documentation by the lab employee. You know, instead of putting this, just one line. Okay, so just one line up and down, missed, subsequently results in 3 patients getting HIV. They did do NAT testing, but that was not completed until several days, actually. They didn't get the result until 5 days after transplant. So obviously that's of no use to anyone getting it at that point in time. And commission was appointed, evaluate, assess what exactly happened. If you look at it, there's really 2. Like I said, failure of the system, failure of the individual. Okay, failure of the individual, they marked it down wrong. That's a medical error, all right? But failure of the system also. So the system was, why was the system at fault? Well, several reasons. The system was entirely reliant on one person documenting by hand that there was a problem, okay? So there was no redundancy built into the system to catch an error if it happened. So that's a problem with the system. If you know that a medical error, that human error is going to occur, you have to have a system in place that'll account for that. If you don't have that, then that's a problem of the system. So there was redundancy lack, and then the fact of having a process in place where you get the NAT testing 5 days later, obviously that's a system problem. The NAT testing was done properly. It showed that the HIV was indeed positive, but it came 5 days after the transplant. Okay, so here's an exercise I want you to do. I want you to read this, but I only want you to read it one time, okay? Simple sentence. Just read it one time, and as you're reading it, I want you to tell me, count, and I'm going to give you 10 seconds to read through it, okay? How many F's are there in that sentence? Okay, time's up. 10 seconds. So, how many saw 2 F's? 2 people saw 2 Fs? Okay. How many saw 3? No, 3 people saw 2 Fs. How many saw 3 Fs? Okay. Okay. How many saw 4 Fs? All right, quite a few more. How many saw 5 Fs? 1, 2, 3, 4, 5. How many saw 6 Fs? Okay, 1, 2, 3, 4, 5 of you saw 6 Fs. 7 Fs. How many saw 7 Fs? Okay, no one saw 7 Fs. Good. There are 6 Fs in that line. Okay? Simple test, just reading it. All you're trying to do is identify the Fs. All right, all right, here's another one. Are there any errors in any of the 3 statements? Okay, and there may not be any errors. There may be an error in just 1, or in 2, or in 3, or in none. Okay. How many saw an error? So only 1, 2, 3, 4, 5, 6, 7, 8, 9 people saw an error. The rest of you did not see an error in that, right? Okay, you saw 3 errors. Okay. Everyone saw an error then in there, right? Okay. Yeah. So that's the error, right? But if you look at it, but you may not, because your brain is telling you that the statement is, and while this is, just a silly little exercise, but when your brain tells you, look, this is a woman who's been married 18 years who has no risk factors for hepatitis C. Why the heck would the hepatitis C test be positive? All right. But it can be. So we spend a lot of time, energy. How can we improve our system? Not just us. I mean, not just us in the medical field, not just us at our institute. This is actually the government is quite interested in how can we minimize the number of errors, and that's because of that figure that I showed you, $30 billion a year going for medical errors. We're all going to have to do computerized patient records and drug prescriptions because those have been shown to decrease the number of errors, right? That's part of the Obama initiative that by 2014, 15, that all health records will be electronic. And that's an attempt to try to decrease the number of errors that are limiting the number of consecutive hours worked. You and I were talking about that just a little bit earlier today, how for some reason in this surgical culture or in medical culture, it's quite acceptable to make you work 120 hours in a week, right? But certainly you're going to make a mistake when you've been up all night for 2-3 nights. And it's the little things that you can miss that are so easy to miss that can have severe consequences. Increase hospital awareness of patient safety. Again, something that Marwan and I were talking about earlier. How many hospitals had patient safety councils or quality control councils or this or that 4 or 5 years ago? There's nothing. QAPI, I didn't even know what QAPI stood for 4 years ago. I know now. It's been drilled into me, I tell you that. All right. Checklists. So that's something that's gaining a lot of popularity. Checklists are not new. The FAA discovered checklists a long time ago. You can't take your plane off without going through a checklist that's about this long. All right? And checklists have been shown time and time again in other fields to make a dramatic difference. And even in medicine. So Atul Gawande, who's he's a neurosurgeon, I think, talks a lot about, what type of surgeon? General surgeon? Okay. General surgeon. Yeah. But he writes a lot about, medical errors and system improvements and system processes. And that's one of his book, The Checklist Manifesto, about using checklists to try to minimize or to diminish these medical errors. So here's an example of checklists. So this is a Time article from 2008. Time publishes, the 100 most influential people, and that can be leaders, thinkers, heroes, artists, scientists, and more. So Peter Pronovost was on the list in 2008, and I think he's a critical care physician, was at Hopkins at the time when that happened. So why was he on the Time list for 100? Anyone know of his work? Right. So he came up with a simple checklist, okay, that everyone was required to do before putting in a central line. And it was simple things. No-brainer steps, he called them. Wash with soap, chlorhexidine, drape the entire body, mask, hat, gown, gloves for the person putting it in, and a sterile dressing. All right, and they actually conducted a randomized trial looking at this, the impact of this intervention, published in the New England Journal, and found that the introduction of checklists, okay, over a period of 18 months in this state that you're familiar with, okay, saved 1,500 lives and $100 million. Just these 5 simple tests and making sure that you did check this off before you went and stuck a needle in the patient. Okay, so let's go away from that and get to the nitty-gritty of it. So the error has occurred, all right, whatever it is. You've missed something, the instrument has been left behind in the patient, whatever the errors. What do you do to manage? All right. So I think there's essentially 4 things or 4 major steps that you need to do when this happens. Report the error. Figure out why the error occurred. So do a root cause analysis. Figure out why it happened. Put a plan in place to make sure it doesn't happen again. Okay, a corrective action plan. And then deal with the consequences of that error. And I'll tell you what the consequences of that error are. Don't do this, all right? Don't play the blame game when something happens, because this is the easiest thing to do. You screwed up, you are fired, all right? It was your fault. You're the one to blame. That's the easiest thing to do, but it's the wrong thing to do. And companies have learned this, okay? Don Norman, he's a system design specialist consultant, works with the aviation industry, Apple, etc. This was a very nice statement from him. People make errors which lead to accidents. Accidents lead to deaths. The standard solution is to blame the people involved. If we find out who made the errors and punish them, we solve the problem. Right? Wrong. The problem is seldom the fault of an individual, like what I had shown you before. There's always 2 components, the individual human error and the system error. It is the fault of the system. Change the people without changing the system, and the problems will continue. So you get rid of that person who made the error, don't do anything else. Invariably, another year will pass, 2 years will pass, and that same error will happen again. Because we're unfortunately going to make another mistake, okay? So the first part is disclosure to the patient, all right? This is not something you can, should, or want to hide. It's going to come out at some point or the other, okay? And you're best to just confront it head on. It's obviously in the best interest of the patient because for practical reasons, it may even change. You may have to do some therapy. It may allow them to get some treatment, whatever. So it's in their best interest to know. It's the fair and ethical thing to do, all right? It's obviously your patient deserves to know, needs to know when something, and you have a responsibility to tell them. You made the mistake. You have a responsibility to fess up to that mistake and tell them. This is what patients want, all right? They want disclosure of all errors, and they want to know what happened, why it happened, how it happened, and importantly, what you're going to do to prevent someone else from this happening too, all right? Invariably, if you talk to the patients right at the very beginning, complete honesty, you show them compassion, apologize, actually, and often these things will not end up in litigation. You would think that it's a big error, things have happened. Obviously, it's going to end up in litigation. But I've been surprised, actually, at some of the cases that I've seen where the patient was approached, you're upfront with them, told them exactly, and importantly, apologized. Humility, okay? That's what patients want. That's what they want to see. They don't want you to come up there and say, well, someone screwed up and, this happened. My team made a mistake. I take responsibility. Me. If you're talking to them, that's what they want to see.
I find that they find it hard to navigate the legal system and may not have the resources to even hire a good lawyer and things like that.
Yeah, though, that's never a problem. You'll find a lawyer who's willing to take it on for no charge because they'll take their 30% cut of they know that. Lawyers are pretty smart. So benefits to the patient, the opportunity to receive corrective treatment, help them to make informed decisions. It allows you to try to build that trust back, okay? Because the trust is lost as soon as that mistake has been made, and you then have to repair that and regain that trust, all right? And opportunity to receive fair compensation. The patient is going to have suffering as a result, could potentially, they may not, but they could potentially have suffering, okay? And it's only fair that they receive compensation to deal with that. Benefits to the physician. It may be that you're less likely to be sued as a result. It may help alleviate the stress because that thing of, when will this come out? When will this be out? You're always wondering when, looking around your shoulder. If it's out there already, you don't have that stress. And as I said, it fulfills, I think, a moral obligation that you have to tell the truth. So, after disclosure, root cause analysis. That's where you sit down and look at the problem in a systematic fashion to figure out what happened. Okay? So that's what we did. We looked at our event in a very systematic fashion to figure out what happened. And the things that we came up with, yes, sure, there was a human problem, but there were lots of other problems. We didn't have enough redundancy in it. That if two people missed it, that's it. There was no other checks and balances on it. If the donor coordinator and the donor surgeon passed it, no one else checked really the chart to make sure that everything was okay. There was insufficient rigor in the selection committee because all it was a verbal presentation. There wasn't a review of the data. Okay, so essentially, the kidney donor coming to recipient exposure, the Swiss cheese model that people talk about, that if it gets through one layer and if the holes line up, it could get through a second. But if you have multiple layers in place, then the chance of errors getting through all of the holes is low. Because each of us is going to have holes in us. There's no question. We can never be perfect. So then the next part is you have to come up with an action plan that corrects those errors that you've identified in your root cause analysis. Right? You identify what are the problems, and then this is what you're going to do to address each of those issues. All right? So we created an action plan. This is what our action plan looked like, was essentially multiple layers of redundancy were built into our evaluation so that there were multiple people checking. All right, so it wasn't just the coordinator. It went from the coordinator to the surgeon and the medical doctor, who both individually, separately did their own checklists to look through all of the things. All right, and then they presented it to the selection committee, and then we had a separate safety meeting before the case was scheduled. This was an independent committee that again went through that checklist and looked at those. And then on the day of surgery, the anesthesia team, the actual donor surgeon, and the actual recipient surgeon each independently verified those results. So you had 1, 2, 3, 4, 5, 6, 7 different steps now, 7 different places where that hepatitis C positive test could potentially have been picked up. So maybe 2 would have missed it, maybe 3, maybe 4, but if any one place it was caught, those would be a hard stop and the process would have been stopped. Okay? This is how we started. This was the initial checklist that we had made. So this is, it's just a simple one-page thing. It just goes through all the various important things, everything from the CT scan, the cardiac evaluation, basic tests, serology, the hematologic workup. And then we took this and then embedded it into our electronic medical system. And my one tells me that you have Epic now as your electronic medical system, which is what we then transitioned to. This was also at a time when we were transitioning to a new medical system. So we transitioned to Epic, and we built actually these checklists right into our Epic system. So now when we screen, so for example, if I screen a donor, I just click on the donor and I click that this is a donor evaluation, and that checklist that I showed you before essentially comes up populated. Okay, and it comes populated from source document. So that eliminates the error of transcription. So it doesn't rely on me looking at the test and saying it's positive and then me entering positive. It just comes into there that the test is positive and in a slightly different color so that it comes out positive. Sorry, you had a question?
According to the electric documentation, where one, you have a source document, two, you're probably doing it completely independent than the other people. Transplanters generally are a very small group of people, even at a very large center. How do you prevent over redundancy, the fatigue of the multiple levels of paperwork where the guy next to you is actually checking the same thing you're checking? So maybe you'll just kind of look at him and say it's good and go kind of fall back on the bad habits.
Yeah, bad habits are hard to break. You're right. Copying from your neighbor is, it sounds funny, but you're right. People do it all the time, and we had to actually separate out the people to make sure that this was happening at either remote different times or different places, so that there wasn't this just looking over and saying, is everything okay? Because you're right. If I do my checklist and I check it, then what's to stop the nephrologist from, just pulling up my checklist and saying, okay, here's the answers. And so to some extent that can happen. You have to rely on people to be responsible. There's only so many things that you can do to prevent these. And so this is that same patient, but now with the electronic medical record and the checklist, and you could see that this would come up. And so what we require is that the surgeon, physician, coordinator each have to look at those, and then they have to look at the results and then subsequently click whether it's acceptable, unacceptable, or that it needs further evaluation. And so here it's clicked unacceptable, and there's a hard stop built in. So if any of those things are clicked as unacceptable, you can't at the end click the donor is okay to go for, or the recipient is okay to go for surgery. Okay, so the last step, manage the consequences. Okay, manage the consequences of that mistake that's happened. So this is a very famous line from a poem by Andrew Pope, who contemporary of William Shakespeare. To err is human, to forgive divine. And actually the Institute of Medicine picked up on this and wrote a position paper by that same title. So yes, to err is human, to forgive is divine. So I'll tell you this much. No one is divine, okay? None of the committees, none of your organizations, none of the regulatory bodies are divine. And therefore, you will not be forgiven. Okay, no one is going to forgive you. If you think that you can make a mistake, fess up to it, do the right things, and they're going to say, okay, good. You did the right thing and carry on. All right? Expect that there are going to be consequences. Just accept it. I'm not saying it's right or wrong. It's just going to happen because we are not divine, and therefore we want to punish. All right?
Abhinav, a representative at the NPSC, when we say the program did the right thing, it was a one-time event, and they did corrective action and all that, and not uncommonly stood up and said that the public deserves more.
Yeah.
And there should be no action without consequences, and we need to restore faith in the health system, and there needs to be lessons learned.
Right.
And
so
that is the government's viewpoint. And
absolutely, and that's reality. So this is not.
That's okay. Consequences are.
Yeah, I'm not saying it's right or wrong. I'm just saying this is, if you think that you can do that, and this is a great statement because the Institute of Medicine has said to err is human, to forgive divine, hodgepodge. That isn't going to happen. The quote that's more apropos when a mistake happens, Julius Caesar, Shakespeare, cry havoc and let slip the dogs of war. It's a feeding frenzy, okay? It is literally a feeding frenzy because we have, especially in transplant, we are over-regulated, and there are so many regulatory bodies, and each feels that they have to do something because if they don't do anything, geez, that was their job. Why didn't they? So UNOS is in on it, CMS, JACO, the media, obviously, and you're down in there somewhere. All right? So just accept that's what's going to happen. And the media, it'd be surprising how the media finds out and how they can do this. I swear, before we reported this to UNOS, and the next morning, and that's a span of about 8 hours, it was on the front page of the Pittsburgh Tribune. Okay? So media, it's going to affect your business, because once it's in the media, it's out to your referring physicians, program is closed, they had a screw up, this, that, whatever. You know, it's hard for referring physicians to send patients if there's a problem. It's hard for patients maybe to come there if they have a choice. And unfortunately, or fortunately, we have a lot of choice in healthcare nowadays. Easy for them to go down the road, even drive an hour or two, and that's it. So we saw a significant decrease in the volume of our transplants as a result of this. Team morale. Okay, this is one thing that people don't talk about, but team morale is critical to all of this. All right. So here's a case from, So remember, with every medical error, there's two casualties. One is obviously the victim, and that's the one that, that gets all of the attention. Okay. One is in a crime situation, obviously it would be the perpetrator, right? But it's not really the perpetrator. They're also the victim. Loss of sleep, anxiety, lack of confidence, depression. All of these are pretty real, and I can guarantee you that your team will feel this. So caregivers must also be considered part of the accident. So here's that case. Again, not very remote. 8-month-old infant given 10 times the amount of calcium chloride that was ordered, and that you can see how that happens in neonatal. And the doses are so small to begin with. You're talking about volumes that are very small. But he gets 10 times the amount of calcium. The infant dies 5 days after the overdose. The RN that gave and made the mistake was a 50-year-old ICU RN, 27 years experience, unblemished record. Okay. But she's dismissed. The State Nursing Commission is investigating the case. She commits suicide. So these are obviously real problems. And I can tell you that the team morale will take a big hit. I mean, there were times when this happened, I felt like literally a psychiatrist, in that my office was open, my sofa was there, people were coming in to come and talk. Okay. So if you're the one that's made the mistake, you need support, tools to cope. If your team member has made the mistake, you need to offer them support. Family, friends, colleagues, human resources, mental health care professionals. Okay, all of those are resources available to the individual team members to help them get through this time period. So in the last sort of 5 minutes, I have about 5 slides that sort of summarize what I've learned through this whole. So you need one person to take charge of this, all right, when something happens. And in my mind, it needs to be the leader of the program, all right? People don't want to hear, this was his problem, this was her problem. You are the leader. This is your program. You take responsibility, okay? Whether you had anything to do with it or not, regardless, okay? Irrelevant. I mean, I was out of town when that mistake happened. Irrelevant. It was my program, my mistake. You need help. So you need a taskmaster to make sure that things are getting done, because you are not going to be able to do all of the things that need to be done, because there are a lot of things that need to be done when something as major as this happens, okay? So you need someone that you can rely on, that you can say, look, please make sure this happens, and you know that they're going to go and make sure that that happens, all right? And as I said, you need a lot of people to help you get through this. The patient comes first. Always remember that, okay? Full disclosure, full honesty, proper care. That's the first part of it. The regulatory bodies, especially in transplant, as I said, we are very regulated, and invariably, you're not going to hide any of this. They are all going to find out sooner or later. Just you're better off to make it sooner, okay? So pick up the phone, meet your new best friends, welcome them to your site, let them see what you're doing, have full transparency, so that, as I said, don't wait for them to call and find out, because they're going to find out. CMS, Department of Health, JACO, all of those are people that you should notify. Approach the problem systematically, all right? You need a root cause analysis, and not by the people who were directly involved with the case, because they can't see the forest for the trees. They've already made the mistake. They know. You need someone independent, outside, looking in, all right? So often most hospitals will have a compliance staff that can help you on this. So approach them and use their expertise. A corrective action plan. As I said, the blame game is very easy. Don't play it. All right? Don't try to pin. Don't look for scapegoats. Don't try to find one person to put this on. Look for and fix system problems. That's the whole thing about all of this. And then continued assessments. Don't just fix the problem and say, okay, it's done, we're ready, let's move on to something else. You want to have continuous regular assessment to make sure that your corrective action is in place and that it's working and that your team is following what you said you were going to be doing. Okay? Because that's what the regulatory bodies will be looking for when they come back to evaluate you, that you're doing what you said you were doing on a regular basis. Institutional support. You need to have your institution on board with you, because this is going to cost you. It's going to cost you in terms of dollars. It's going to impact your business. Okay? So they need to be aware that this is going to affect their bottom line for at least some period of time. And they have to be committed to that. And they have to be committed to fixing the issues. They have to be in it for the long haul. Most of these problems, when they happen, suggest that there's a systemic problem. And that doesn't get fixed overnight. It needs multiple things and needs time to fix it. So the institution has to be behind you and supportive of you. And they may not be. And if they're not, the easiest thing for them to do is close the program down. And there are several cases, actually, of that, where it decided that the hassle of supporting the program through all of this was not worth it, and folded the program. Keep the doors open if you can. So, if you can make it seem as normal as you can, I think that that's a huge thing. And it's for several reasons. One is for your referring physicians. One is for your patients. You don't want them to think that everything is closed down. Never let them think that, because if they do, you'll never get patients back. It's very difficult to reverse that thought once it's planted in someone's mind. Okay? But you also need to keep business operations as normal as possible because of that other thing that I talked about, which is your team morale. All right? If your team needs to be focused. They need to do their job, and their job is to look after patients. So they need to keep doing that. All right? It's why they come to work every day, and they need to concentrate on that, not on, who's coming banging on the door, what, where the reporters are, etc. And that can be sometimes difficult to do when the reporters are showing up at the house at night, or they're stalking them, and all of that, that happened. This is key, communication plan. You need a great communication plan in multiple directions, not just for the media, though you need a good media strategy. And most hospital corporations will have a media team that can help you with this. But you need to be out there. Don't let your hospital spokesperson, that's one thing I've learned, don't let them be the spokesperson for you, because they don't know what happened. They don't know the details. They don't know what to say. And they're not the face of the program. You're the face of the program. You can get their help, but you have to be the one in front of the camera, on press, in print. You need an internal strategy, okay? You need to have lots of frequent updates with your own staff. Because if you don't tell them, they're going to hear from somewhere else. And what they're going to hear from somewhere else is going to be a lot worse than what you're going to tell them. They're going to hear from the media, or they're going to hear from rumors. And everyone knows about rumors. They're worse than the truth. So you're best to sit down with them. And when this was happening, I would sit down with the staff almost on a daily basis, coordinators, nurses, etc. Give them an update on what was happening, what was going to happen, what the plan was, etc. Patients, okay? The regulatory agencies will require that you notify the patient. You have to actually send them a letter notifying them that this has happened. But again, don't let your PR people do that letter. Write that letter yourself, which is what patients want to hear. They don't want to hear some gobbledygook coming from some administrator. They want to hear something that's coming from your heart, literally, okay? That you made the error or your team made the error, this is what you're doing to fix it, that their care is not going to be jeopardized, etc. And you want to craft that in your lingo, not in PR lingo. Referral sources, as I said, don't let them get the impression that things are shut down. And that needs often a verbal communication to do that. And we literally got on the phone and called every one of our referral faculty, of our referral MDs, and told them, look, this is what's happened, but we're still seeing patients, etc., etc. If you have any questions, call this number. And lastly, remember your team, okay? Do what you can to keep up the morale of the team, because there's a real danger of being paralyzed by fear. You know, there was a time period where we couldn't approve a donor. I mean, we just could not approve a donor for donation because everyone was literally scared to click off at the bottom, yes, proceed to surgery. Because what if we missed something and there was a problem and then you were the person who approved them? So they have to get over that fear of making that same mistake and being paralyzed by it and not being able to work as a result of it. And lastly, in the words of Winston Churchill, if you are going through hell, keep going. Persevere, okay? I look back through that 1 year period of time, or even that time before, it was tough. It was very tough. I mean, the amount of scrutiny, the amount of backstabbing, the amount of whatever. You know, when you pick up the paper every day and read about how you screwed up, it wears on you after a while. All right? But persevere. There's no question that when I look back at the way we evaluate our patients right now compared to how we used to evaluate them, we are much better. Okay? We are much more careful. I'm confident in the system now that we're not going to miss major things, etc. And when I look back on it now, I think, geez, how did we ever get patients through before? So you come through it, I think you come through it stronger, even though it's tough. What doesn't, you know, all these cliches you hear, unless you've been through them, you just think of them as cliches. What doesn't kill you makes you stronger. It definitely does. Definitely does. So I'll stop there and take any questions.
Thank you, Abhi. I have to applaud you, and I admire your courage and your big shoulders to support all this. I wonder when you went through this experience, and probably many of your staff became very diligent or super diligent to almost an extreme.
Yeah.
And you probably had some change of staff over this period as well, intentionally or unintentionally. How do you maintain the institutional memory that the reason why you do things, as Jason said earlier, maybe too redundant for some, but it's for a reason, then you have new people coming and they say, what the heck is that? That's a waste of time. We want to do so many donors in so many days and so many transplants, all these metrics. How do you do that?
Yeah, the attrition is, you're right, there's going to be some attrition through any problem like this. You'll find that people are not willing to get on board with the changes. Some are convinced that, look, this was not my mistake, this was their mistake. Why am I having to pay for it as a result? And those are people that you probably are best to not have on your team, and find them a gentle way to move elsewhere. The thing of becoming over redundant, I think, is real, because, as I said, the paralysis with fear was very real. We could not approve a donor for literally, that every little thing was a problem. And then you get into this, well, maybe we should do this test to look, and this test, and at some point it just becomes too much, and then you just have to sit down with the team and say, look, let's look at the bigger picture. And it's just regular meetings with everyone to look, this is our goal, we want to get there, we have to fix these issues. We're not looking to get through a lot of donors, but we want to do the right thing. And to make patients go through umpteen number of redundant and unnecessary tests is almost as bad as missing tests in some ways. So,
Question to the floor? Yeah.
Have you found the formula of, I mean, you have a leader, you have people that work together, and you have to rely on each other, but it's not like, oh, that's not my business, someone else's business. Like, I'm not going to worry on that. Have you found a formula where people can still care what the other one is doing? It's like a double check, like that redundancy. Like X has one job, Y has Z job, and the other one, but there's a flow to it. They're not completely separate instances. And I think that one of the things that happen, especially as you grow bigger, is that people rely so much on someone else doing that. That's not, I don't have to worry about that. That's kind of none of my business. That's where the crack happens.
Right.
And I think that happens when you have timeout.
Yeah.
Like, oh, yeah, we have to all check it, or someone else check it. I mean, have you guys, with your experience, learned how to deal with that? That people still doing their own thing, but still are redundant with each other?
Yeah, you're right. That is a problem, and so in that system, what we tried to do with the multiple steps is that in there, some of the steps are people that are not directly involved with the case at all, so that are literally coming in there with a fresh set of eyes, and so that they can't say, well, this is not, So for example, the Living Donor Safety Committee meeting is made up of a surgeon and a medical doctor and a coordinator who have not seen either the donor or recipient at all beforehand. So they're looking at that chart for the first time and are looking at it with a fresh pair of eyes. And so it's not that they had already seen it before. So that's a little bit trying to address some of those issues. But you're right, everything is very compartmentalized, and we are trying to have more cross-reacting over so that you can, learn from the other team's mistakes, and plus get a fresh set of eyes to look at things that you may miss because you've seen it so many times.
For your living transplant reviews, do you review the donor's chart and the recipient's chart with a third person, like both charts, or just one?
Both.
Okay.
So they're looked at to make sure that but they're looked at not for the entire thing. They're looked at to look at the major things. Are they ABO compatible? Is the cross-match okay? Is the serology compatible? Those type of things. Otherwise, again, then you get, you don't want to then, at the last step, start talking about, well, look at the creatinine clearance on this. Is this an acceptable creatinine clearance for them to donate? Because hopefully that medical decision, all you're checking are the major, the things that have to line up for the transplant to happen.
Limited review.
Yes.
And then, so you have whichever physician and surgeon evaluated the donor, you'd have a second physician and a second surgeon review that same donor.
Yes.
And same thing for the recipient.
That's right.
And do you feel like the surgeon part is important too? I'm trying to gauge it compared to our program.
So I think that the surgeon part, there's a surgeon and a medical. So when that safety review, it's not two surgeons, two medical doctors. It's one surgeon, one medical doctor, and one coordinator who sit and then go through the chart of the recipient, the donor, and of those two, and make sure they're compatible. So you're saying that is that surgeon necessary in there?
Right, yeah, it feels like it's more of a medical work. Do you know what I mean? Like, it feels like it's more like...
That's not
It's neither, it's not even a medical. I mean, that job could be done by anyone, literally, because all you're checking is to make sure that blood type is compatible, that the cross-match is negative, and that the HIV, Hep C, hepatitis B are negative. So it could be done by the medical student, if need be, but those are the people that we have on the team to do it.
There's more ownership as well in the back. Yes.
Reimbursement rates, like, what are the insurance companies saying if you've already done this test and you're being over diligent, tests are redundant? Are the insurance companies saying you did this once and now the hospital has to take the cost of being careful, or are those reimbursement rates still?
So most of those don't matter because that's all coming in your
It's
global
a different bucket. Yeah, it's a different bucket.
Right.
All the testing before transplant goes under one bucket, and then the transplant center tends to average those costs over a year and include in that other administrative expenses, and that's what they deliver to the payers. So that tends to be all bundled together. So it won't matter on the police side. It's just a matter of budgets and protocols. Yes?
How do you handle test results from other institutions like ABO
So the ABO, the serologies, and the cross match we require to be done at our center. But other tests, like for example, if they want to have a CT and they're having it done elsewhere, that can potentially be done elsewhere, and they can bring the disc and test like that. But we try to do as much as we can internally. Our donor and recipient evaluation is all set up to be done over a period of 1 day. So they come in 1 day, they have everything done.
Can you tell me more about morale and I sense that the issue of morale is pretty significant when events happen, and even when people are asked nicely about events, they feel that they are responsible, and it's hard to really wipe that, and tends to be contagious. What was your approach short of the one-on-one? Was there anything systematic you felt that was needed? Team approaches or any other approaches?
So the communication is a big part of it. I think keeping the team informed as to what's going on. Every time there was an article in the paper, we would have a meeting to go over it, because it's always blown out of proportion in the media. And so keeping them abreast of what's happening, that's important. Time. Time heals many wounds. Unfortunately, it takes time for that to happen. And certainly the team is much better now than before, but that memory is still there in everyone's minds, and I'm sure has an impact on their working. Yeah, some of it has bounced back. So for example, in our kidney volume took a dramatic hit for a short period of time, and that's all bounced back, and that's recovered at this point. But it took, I'd say, the better part of a year for that to happen, because we were on probation for a period of 1 year, and it's and as I said, when after that year period of time, when I can just remember recently seeing patients in clinic and saying, "Oh, you're finally doing transplants again. That's why we decided to come here now." Said we never stopped doing transplants. So
I mean, clearly there's a big challenge there, because transplant, as you can see from the safety and complexity of procedures, you have a large number of staff that need to be on board, and when you drop your volume, your margins are very narrow. So actually, the program will lose a significant amount of money.
right.
And the institution will have to say, we're in that business, because they're not going to lose skilled personnel and say, sorry, we are smaller, go. And then when we're big again, come back, because everybody took so many years to become an expert.
Right.
So that's part of the dynamic, I think, that's probably important in your program, how to
Absolutely.
preserve the workforce.
Yeah.
Right?
Yeah.
So, all righty. In the back, Carol, first.
When you made the corrective action plan, did you involve like the coordinators and the surgeons and the medical, did you involve everybody?
Yes. So we had a committee, and it had representation from all the different, including anesthesia, coordinators, nursing, surgeons, medical people, etc.
Hasina?
One is a comment and then a question. The comment is, I like that you guys have a separate committee that looks at both the recipient and the donor and looks at their compatibility, so that's very good. That's something we're not going to do. And did you guys lose any insurers during your probation period?
So when you are on probation, some payers can say that as one of the requirements for getting into their network, you have to be in good standing. That can be one of their requirements, so that you have to be a member in good standing with UNOS. So that only has an impact if you're trying to get a payer. If you're already part of their network, they can't kick you out.
Yeah, and remember, if you remember, not in good standing is one step past probation.
Past
That's
probation.
what they call the meningus, and that's
Yeah.
the label there. Any other questions? Well, thank you so much, Dr. Humar.
My pleasure.
That was great.